When a child has been diagnosed with Alport syndrome in a definitive manner, I think it's also very important for the parents to be evaluated for Alport syndrome. On occasion, they may go undiagnosed for years when the introduction of therapy could be, in fact, very beneficial to them as well. So diagnosing it within the whole family is very, very important when a child has been diagnosed with Alport syndrome. I think it's very reasonable to screen asymptomatic siblings of children who have Alport syndrome for the disorder themselves. With genetic testing, one can really get the answer in terms of whether or not the siblings have Alport, and in turn, whether therapy should be started very, very early in that child's situation. I think it's very important to confirm the diagnosis of Alport syndrome, even in the individual who has clinical symptoms that are most compatible with that disorder. By doing genetic testing in many of these children, it can give us very important prognostic information. And I think knowing the diagnosis in a definitive manner also will inform the physician about the necessity or the desire to initiate therapy, in particular, ACE inhibition or ARB therapy for that child. So the question often comes up, what is the preferred approach to the diagnosis of Alport syndrome? Is it genetic testing or is it kidney biopsy? And I think in 2022, genetic testing is indeed the gold standard, if you will. And in most cases, it can make the diagnosis. But on occasion, the abnormality, the mutation of the genes is not evident with genetic testing. And in those situations, performing a kidney biopsy can be very, very helpful by looking at the changes in the biopsy that can be very suggestive of the diagnosis of Alport syndrome as well. Now, the other side of the coin is, what about patients who have had a kidney biopsy? Is genetic testing important? And I think it is. Number one, it will help confirm the diagnosis that may be suggested by the kidney biopsy. And the genetic testing can also give some very important prognostic information for that individual child. When genetic testing is being recommended for a patient who likely has Alport syndrome, it's important to recognize that one can really go to their primary care provider as well as to a nephrologist in order to obtain that evaluation. So point out that, again, in this day and age, the primary care provider, the specialists all recognize the importance of genetic testing for children who may have the diagnosis of Alport syndrome. And so either one of those can assist the family in carrying out that evaluation. Once a family has received or has undergone the genetic testing for their child and has a diagnosis of Alport syndrome, clearly many families need additional information about what does all the genetic information mean. I think in many situations, a genetic counselor is the perfect place to go to really help understand the implications of that genetic information for the child and for the family. Of course, the primary care physician, the nephrologist may also give one additional information, but the genetic counselor really has that information for you and is a great source to go for additional education about the results of the genetic studies. I think in most cases, it's really very beneficial for families who have a child with Alport syndrome to be seen by a nephrologist. And I will tell you that most pediatric nephrologists do have experience caring for children with Alport syndrome. And so that is probably your go-to place to get information and to, again, receive the care that your child deserves to have. In a situation where a family is being cared for by a physician who does not have experience with Alport syndrome, I think in those situations, one can certainly talk to their nephrologist and see if they have recommendations for other care providers that the family may see, or they can go to the Alport Syndrome Foundation and also get recommendations for physicians from throughout the country who have experience with Alport syndrome, who can provide the family with important information pertaining to the care of their child. So when a family and a child with Alport syndrome is seen by the nephrologist, there are a couple of important topics to be brought up for discussion. One is the presence or absence of protein in the child's urine. We know that protein in the urine is associated with injury to the kidney. And we initiate therapies to try to minimize the amount of protein in the urine. So knowing how much protein or whether there's any protein at all in the child's urine is most important. Another very important factor to talk about is blood pressure. High blood pressure can also injure the kidney. So in a perfect world, we're keeping the blood pressure normal in the child, and we're having no protein in the urine if at all possible. But these are two important issues to be discussed with the doctor. Now, one other thing I should also mention is the serum creatinine. This is a blood test, and a creatinine is a measurement of kidney function. And so this is something that nephrologists use to assess the degree of kidney impairment or kidney injury. And that's another test that should be discussed at every visit with the nephrologist. There are a number of different laboratory studies that are conducted on children with Alport syndrome over the course of their disease, and that may be certainly a topic of conversation at every visit with your physician. So what are some of those tests we're talking about? The serum creatinine is an important blood test, and this is a test that helps evaluate what the kidney function is. A lower serum creatinine is better. A higher serum creatinine is associated with more kidney impairment, kidney injury. And that creatinine value is also used to estimate what we call your GFR, your glomerular filtration rate. And the GFR is another means to look at the kidney function. A lower GFR means that there's more kidney injury. A higher GFR means better kidney function. So important tests. Now, the other tests in the blood that we look at are what we call the electrolytes, the sodium, the potassium, the chloride, the bicarbonate. And I want to highlight potassium. That's an important test that we look at for patients that are receiving what we call RAS inhibition or therapy with the ACE inhibitors or the ARBs, two medications that are oftentimes used in patients with Alport syndrome. In some situations, especially in situations where the kidney function is poor, the use of ACE or ARBs can lead to high potassium levels, or what's called hyperkalemia, and that requires attention by the nephrologist. So the potassium level is another important blood test that we'll want to look at on a regular basis. Now, in the urine, there's two issues or two things that are followed. One is the presence of blood, and one is the presence of protein. Blood in the urine is called hematuria, and you don't see that really on a blood test, but you see it on a urinalysis, on a urine test. And when one looks under the microscope, one sees red blood cells. So the presence of red blood cells in the urine is hematuria, and it's something that's seen in virtually all children with Alport syndrome. And then lastly is proteinuria, or protein in the urine. And we measure that in the urine, and we sort of report it out as the urine protein creatinine ratio in many situations. A normal protein creatinine ratio in the urine is less than 0.2. And a value higher than 0.2 means that there's more protein in the urine. And protein in the urine, again, can be associated with injury to the kidney. And it's one of those targets that we try to treat with the ACE inhibitors or the ARBs. So in the urine, we're looking at red blood cells or hematuria, and proteinuria. Again, we're going to evaluate by doing the urine protein creatinine ratio, or sometimes what we call the dipstick in the urine, where the amount of protein in the urine can be 1+, 2+, or more than that. But the urine protein creatinine ratio is really the value that most of us utilize now to evaluate the quantity of protein in the urine. Questions have arisen recently about the utilization of a blood test called cystatin C to help assess kidney function in children and adults. And in fact, cystatin C is a very good test when trying to determine what the estimated kidney function or estimated GFR is for children and adults with Alport syndrome. Now, the problem with cystatin C is it's not available in most laboratories, in most hospitals, and it has to be sent out to central laboratories. And there's several days turnaround time. And it's also a more expensive test than the blood creatinine is. But I think more and more you will hear more labs utilizing cystatin C. And as I said, it is a good test. And it's something in my own center that we're now utilizing to measure and follow kidney function in children. Questions often arise as to whether or not an ultrasound evaluation of the kidney is important for children with Alport syndrome. While many of these children may have an ultrasound obtained early on in their course of kidney disease, I don't believe that repeated ultrasounds are at all necessary in most children with Alport syndrome. Most children with Alport syndrome who have normal kidney function can be seen on average approximately every 6 months, twice a year. But the frequency with which patients are seen will change with progression of kidney disease, with more injuries to the kidneys. So as the kidney function decreases, in most situations, children will need to be seen on a more frequent basis, maybe 3 or 4 times a year, so as to evaluate the impact of any therapy and to make sure that things such as blood pressure is well controlled and the protein in the urine is as minimal as possible. At present, there are no therapies that are specific for Alport syndrome. At the same time, the use of ACE inhibitors and ARBs has been demonstrated in a number of different studies to significantly delay the progression of Alport syndrome. And so that's why these drugs are recommended for virtually all patients with Alport syndrome who have proteinuria. And in fact, for children who have autosomal recessive disease or X-linked disease, they should be receiving this therapy at the time of diagnosis. Now, what are the most common side effects associated with these medications? One could be syncope, or what we call orthostatic hypotension, low blood pressure, and certainly in patients who have worsening kidney function, hyperkalemia, or a high blood potassium level. And so that is why we have to routinely check the electrolytes, the blood potassium levels of patients with Alport syndrome who are receiving ACE or ARB therapy. So most patients with Alport syndrome should receive therapy with either an ACE inhibitor or an ARB as a means to delay the progression or slow the progression of the disorder. And we gauge how much medication should be given based upon the urine protein. We want to minimize the urine protein and base it on the tolerance of that patient for those medications. Now, in some situations, utilizing an ACE or an ARB alone will not control the urine protein. And in those situations, one can consider utilizing a combination of ACE and ARB therapy. And on occasion, that can actually further reduce the amount of protein in the urine. But one also has to keep in mind that there are risks associated with using the combination of therapy. And this is something that will need to be discussed with your nephrologist so that they can review with you the pros and cons, if you will, of this combination therapy. It's important to recognize that in the very, very young children who are diagnosed with Alport syndrome, we generally don't recommend initiating therapy with an ACE or ARB medication until they're somewhere between 12 and 24 months of age. And thankfully, both the ACEs and ARBs come in both a pill form and a liquid form. So for the very young children, the infant, or again, the child less than 5 years of age, as an example, they can receive the same therapy in a liquid format, whereas the older children can receive a pill form. The use of ACE and ARB therapy can cause low blood pressure in patients. And how might that manifest in your child? They may be tired, they may be fatigued, they may be dizzy at times. And so it'll be important in those situations for number one, that information is reported to your physician, and that blood pressures are evaluated in your child, because remember, the ACE and the ARB therapies, while they help delay the progression of Alport syndrome, they are blood pressure medicines. They are medicines that we use for patients with high blood pressure, and thus they can cause low blood pressure as well. So one needs to look for those symptoms in your child. I should also mention, because they can cause some dizziness, some fatigue, it's oftentimes recommended that these medications be given at night so that while the child is sleeping, they're more tolerable of these medications and aren't having the symptoms throughout the day. I think the other important approach in these situations is to make sure that the children are well hydrated. Certainly anybody who's dehydrated at all and then receiving an ACE or ARB therapy, which can lower your blood pressure, can make it even more likely that the child will have problems. So good hydration, uh, good nutrition, and the potential utilizing the medication before bed might be the best approach to, again, increasing the tolerability of the ACE and ARB therapies by your children. One might ask, what does tolerating a medication mean? Well, I think we look at the overall well-being of the child. Now, if a medication is causing a child to be fatigued, to be tired all the time, not to be able to perform well in school, then that medication is not being well tolerated. Now, we know that all medications have the potential of having some side effects, but we don't want these medications to really alter the quality of life of the kids. So any medicines that we give to children, we would ideally have the medicines that are working, that are efficacious in trying to, again, decrease the amount of protein in the urine of the kids, but at the same time, not having an adverse effect on their overall well-being. So the children still feel good, they're doing well in school, their appetite is good, they can be involved in extracurricular activities like all their friends. That would be tolerating the medication well. Anything less than that, again, needs to be discussed with the physician to evaluate what might be going on with that blood pressure medicine, how low is the blood pressure in the child, are they staying well hydrated, all the issues that might compromise the overall well-being of the child. When we initiate therapy with an ACE or an ARB, we'll generally initiate it at a sort of a low level, if you will, and then progressively increase the dose over a period of 3 to 4 months to the maximal tolerable dose for that patient. Now, again, there is a peak dose that we want to achieve in an ideal manner, and that's what we aim for to see if we're going to be getting the best possible effect of that drug. As I mentioned previously, the medications, the ACE inhibitors and the ARBs are the most important intervention that we can use to slow the progression of the kidney disease associated with the Alport syndrome. I think other than that, it's most important to control blood pressure, to make sure the children has good nutrition, and that we follow the laboratory data on a regular basis with the nephrologist. As kidney function worsens, there are factors that might influence the worsening, further worsening of the kidney function. For instance, high phosphorus levels that can be seen when the kidney function is significantly impaired can cause further injury to the kidney. So regular monitoring of the laboratory data, ACE and ARB therapy, good nutrition, good blood pressure control, these are all the factors that one has to take into consideration and really practice to try to again, improve the overall status of the child and to minimize or slow the progression of the kidney disorder. It's very important to recognize that we've come a long way in our understanding of Alport syndrome and the treatment of the disorder. And I think, again, in 2022, we recognize the great value of the ACE inhibitors and the ARBs in terms of delaying the progression of the kidney disorder. And we recognize the importance of all the other factors that we've mentioned, nutrition, blood pressure control, and so on. And so I think if we practice all of those interventions, if you will, and closely monitor our kids, and again, have a good relationship between the child, the family, and the healthcare providers, I think the outlook for the vast majority of children with Alport syndrome is quite good. It's most important that the children who have Alport syndrome develop a progressive increased understanding of their disorder. I think when children are very young, 2, 3 years of age, they really don't understand the disorder, and they oftentimes probably don't even understand why they're going to see the doctor. But I think as they get to be 5, 6 years of age, I think they begin to have an understanding of the disorder, not so much the name of the disorder, but why are we checking urine and why are we checking blood? And I think, that important education needs to start early on, because the children have to be important advocates for themselves. And over time, it's going to be extremely important that they are well educated about their disorder, because self-management is going to be key as they approach adolescence, where the issues of medication adherence taking the medicines that they're prescribed is so important and sometimes very, very challenging. So I think one has to look at every individual child differently in terms of when you introduce education, how you would introduce education, what kind of information can the child receive and understand. And I think you can work with your nephrologist, with your dietitian, and with other members of the healthcare team to sort of get a good strategy to understand how to best educate your child on a progressive manner so that, again, as they grow, they really become their own advocate, their best advocate, and really understanding their disorder in a way that can benefit themselves over the long term. In my patients, what I'm always aiming to do is to optimize their quality of life. I want them to be as normal as possible. And so I think kids with Alport syndrome should be encouraged to exercise, to be involved in as many extracurricular activities as they want to be involved in. But we also have to keep in mind their unique situations. And so if they're taking ACE inhibitors or ARBs and their blood pressures are a bit low, they need to recognize that. And they need to recognize where those medications and the impact of those medications may have some influence on what they can tolerate in terms of extracurricular activities. We also have to keep in mind that, again, they need to stay hydrated, right? And so if they're involved in activities such as cross-country running, they need to be hydrated well because, as I mentioned before, utilization of ACE inhibitors and ARBs and again, poor hydration can lead to significant falls in blood pressure and again, a decrease in the overall well-being of the children. So involved in activities is important. It's important for well-being. It's important of quality of life, but one should recommend those in the setting of the therapies that these children are in fact receiving. The nutritional management of children with Alport syndrome is essential. Good nutrition is important to their overall well-being. And it becomes even more important in many situations as kidney function declines and one needs to modify the diet so as not to have any negative impact on the kidney function. So when one requires those nutritional recommendations, I would recommend seeing a pediatric renal dietitian. They really are the experts in nutritional management for children, and in many situations, you will find the pediatric renal dietitian has that particular expertise with respect to children with kidney disease, and they should be sought out when nutritional modifications would be in the best interest of the child. Parents are the most important advocates for their children who have Alport syndrome. I think you want to make sure that your kids are educated about their disorder. You want to make sure that the kids are following the recommendations of their healthcare providers so that they can have the best possible outcome. You don't want the disorder to control your children. You want the disorder to be something that the children can help control. And I think that whatever support you can give them to that end is most beneficial to them. So you now have a child in your family that has been diagnosed with Alport syndrome. Where do you go for the child? Where do you go as a family? I think you need to work as a team. And all the patients I see, when there's a team approach, that family approach to addressing disorder, and again, allowing for the child to have the best quality of life and the best preservation of kidney function, that's when the outcomes are phenomenal. And I've always been impressed when I look at children with Alport syndrome, that they almost always have an extraordinarily supportive family that works together to achieve the best possible outcome. And I think that team approach, and again, family, child, and healthcare providers all together, I think, can lend itself to really having the best possible outcome for the children and for the families.